likely to be repealed. And the reason is really simple. If it is in fact illegal for Congress to require all citizens to access and purchase health care, since 1965, every individual in the United States who is employed has been required, it is not optional, has been required to purchase Medicare coverage through your Social Security contribution as enabled by various statutes. And to this day, every employer in the country withholds money from your earnings to assist you in purchasing Medicare coverage. And so, as the courts have said, they believe in one particular district court that they believe this may be unconstitutional. No one, to the best of my knowledge, has challenged the constitutionality of Medicare. And if the courts were to hold that this was in fact unconstitutional, one could assume that that then would also apply to Medicare. So in my opinion, although there's a lot of discussions about this in the country, and a lot of the country and citizens are sharply divided in the statistics I was looking at last night, 1/4 of the country believes that the law should be repealed, and 1/4 of the country believes the law should be expanded. Half of the country is in the middle. And so given that, and given that every state in the country except one has taken the planning dollars to implement and begin the process of the Affordable Care Act, I would suggest to all of you listening that this is likely to become the law of the land. Now, that doesn't mean that certain parts of the act won't be changed or repealed. So let's go in and begin talking about what is actually in the act and what do we mean by health care reform or the Affordable Care Act. This was the statement that the President issued shortly after signing it, and whether you agree or disagree, this certainly is a remarkable piece of legislation to begin transforming health care coverage in the United States. If we look at what this law is intended to do, one of the primary areas that it is focused on is what are called insurance market reforms. And there are really several things that Congress and the President intended as part of the statute to eliminate barriers that insurance companies have placed which limit people's ability to access health insurance, beginning with no discrimination based on pre-existing conditions. The whole concept of a pre-existing condition risk plan for individuals that cannot get health insurance because of pre-existing conditions, and that's a temporary measure, and we'll talk about that. Lifetime and annual benefits caps. Many individuals in the country, as they talk to Congress and the President about health insurance, explained that they were not able to access health care because they had already exceeded either a lifetime cap because of the amount of health care that they had already used, or exceeded a yearly cap because the insurance companies had spent too much on them. For the first time in this country, there is a focus on preventive care. And so the health care reform is really about how can we help individuals prevent more disease and disability as a result of conditions that they have. Another provision looks at how can we ensure that insurance companies do not unfairly drop individuals simply because they're now faced with a high-cost claim and they found a mistake on the person's paperwork. The President and Congress heard clearly from a number of individuals who had discovered all of a sudden, I have cancer and I'm facing much-needed treatment for the cancerous condition. And yet because I made a mistake on my insurance application, the insurance companies were permitted to disenroll me. And last on these insurance market reforms, but certainly not least, is the extension of coverage for young adults. So I'd like to go through each of these and give you a little bit more information about what each of these are. So the pre-existing condition clause, and in general, let me start by saying the effects of the legislation take effect at various points in time between September of 2010 and the bulk of the Affordable Care Act comes online in 2014. There are a number of provisions that extend out as late as 2018, but I'm going to focus on the parts of the Affordable Care Act that most directly affect individuals with disabilities and their families, i.e. people in New York State who would use typically the public mental health system. So let's begin by talking about this concept of pre-existing conditions. So a pre-existing condition is a health condition that you have before you get health insurance. And historically, many health insurance plans denied treatment for any condition that you had before you got the health insurance. Under this statute, beginning in 2014, health plans will no longer be able to deny you getting coverage because you have a pre-existing. They will no longer be able to charge you a higher premium for that coverage. They won't be able to exclude any benefits related to your condition. So if you have diabetes, cancer, high blood pressure, a mental health disorder, or any other pre-existing condition, beginning in 2014, new health insurance plans will not be able to limit your benefits except to the extent that everyone's benefits are limited for those conditions. They won't be able to rescind coverage after you are injured or acquire a new condition, and they won't be able to impose annual caps or limits on how many benefits that you can use. Now, one exciting thing that many parents of young children have found is that many of these provisions take effect for children beginning last September in 2010. Between now and 2014, adults with pre-existing conditions, insurance companies can still discriminate, if you will, for lack of a better word, against them until this law fully takes effect. In order to provide health care coverage for those individuals, the Affordable Care Act created what are called pre-existing condition risk plans. Now, this is a specialized insurance that is available for individuals who are not able to get access to health care, not able to purchase it because they have some pre-existing condition or have been denied health care because of a pre-existing condition. So in order to be eligible for this, the plan in New York State is actually run by Group Health Incorporated. You have to be a U.S. citizen or legal resident. You have to have been uninsured for at least 6 months. So this pre-existing condition risk plan is really for people who are uninsured and cannot access insurance. You have to have a pre-existing condition or been denied coverage because of some health condition that you may have. So if I were to have complicated diabetes, if I were to have multiple sclerosis, if I were to have a developmental disability, or if I were to have schizophrenia, and I had been denied health care coverage as a result of that condition and had not had health insurance for 6 months, I could be eligible to purchase this pre-existing condition risk plan. Now, this insurance, and this is a type of insurance that you're eligible to purchase, covers primary and specialty care. Well, what does that mean? It means it covers the physician who would regularly see you and any types of specialty care that you may need, covers hospital care and prescription drugs. The health insurance premium, which means the cost that you would have to pay to buy this insurance, is dependent upon how much income that you make, and the premiums in New York State run from $362 a month to $421 per month. Now, the nice thing about this plan is there's no deductible, so you don't have to pay anything to get access to most of the provisions under this insurance. And there is an out-of-pocket expense limit. So what does an out-of-pocket expense limit mean? Well, it means that as I'm paying for certain things myself, or if there are certain co-pays, not deductibles, but co-pays for certain conditions or treatments that I have to pay myself, I'm limited to $5,950 in any given year, how much I would directly have to pay myself while having this insurance. And after I've paid that, then the insurance provides a catastrophic level of care and covers the remainder. Now, to date, 201 uninsured individuals in New York State have enrolled and actually taken advantage of this new benefit as a result of the Affordable Care Act. There are a number of health insurance market reforms, and we talked about benefit caps. Now, a benefit cap is how much health care does an insurance company have to pay for in any given year or over anyone's given lifetime. And Congress and the President heard from a number of people as they were debating this plan that there were limits, sometimes lifetime limits, sometimes $500,000, $750,000, $1 million for a lifetime of care, that says if over, let's say you're fortunate enough to live to 100 years, if over that 100 years you spent $5,000 a year on health care for a particular disease or illness that you had, you could easily reach a lifetime cap of $500,000 and then no longer be covered by that insurance for that disease. The Affordable Care Act immediately takes the lifetime caps off of any expenditure. Now, between now and 2014, the annual benefit caps are raised until such time as there is no longer an annual benefit cap. So what does this mean? It means that if all of a sudden you're affected by a catastrophic disease or illness, and I'm going to, in the course of today, regularly use cancer as the illness that I'm going to talk about, because for many people that is something that is all of a sudden discovered, and people find that the expenses related to it can exceed anyone's ability to pay for it. In any given year, if you were to encounter that critical incident, you could instantly spend a lot of money in health care to get your needs met. So between now and 2014, the annual limits are being raised. For this year, until September 23rd, the limit annually is now increased to $750,000. And let's face it, you'd have to be pretty sick to need that level of care. But if you are, you certainly don't want all of a sudden to run out of health insurance. Between September of this year and September of 2012, the limit goes to $1.24 million. And between September of 2012 and January of 2014, the annual limit, or the amount that an insurance company would need to pay for your care, increases to $2 million. After January of 2014, there are no longer any annual limits, and so the care that you receive in any given year is the care that you need, regardless of cost, as long as it is medically necessary. So let's look at another one of the benefits of the Affordable Care Act, which is preventive care coverage. Now, this is one of the areas, and most of healthcare reform is actually fairly simple if people can explain it to you correctly. But this is one that gets a little complicated, and the complication is because of when this benefit takes effect. And this benefit takes effect when a new health insurance plan is created. So if you're on a health policy which is paid for by your employer that might be a 5-year plan, this benefit will not take effect until your plan is renewed, and the renewal occurs after September 23rd of 2010. But here's what the plan covers. For the very first time, it requires health insurers to cover preventive tests and services, including simple things like blood pressure, diabetes, and cholesterol tests, are covered with no copays. Cancer screenings, including mammograms and colonoscopies. Counseling on quitting smoking or losing weight. Eating healthfully, treating depression, or reducing alcohol use. Routine vaccinations and flu and pneumonia shots are all now covered once your health insurance plan becomes responsible to cover them under this act as part of the preventive care coverage. Now, plans, as I said, come online at different points in time, so you'll need to look at when does your plan benefits take effect. And so if you start a plan and the benefits begin after September of 2010, it is likely your plan is a new plan. There are a couple of limits to this, but generally speaking, preventive care will be covered. Now, as I said at the beginning, Congress and the President heard a lot that health insurance companies sometimes would drop people from coverage if people all of a sudden found out they had a catastrophic illness and the insurance company could find some loophole in their paperwork. The Affordable Care Act actually says this cannot happen, so unless you have intentionally committed fraud or some other intentional act of omission, if it was simply an error on your part, the plans cannot drop you. Now, that doesn't say that if you don't pay your health insurance premiums, that the plans can't drop you. If, in fact, you don't pay your premium, the plans can, in fact, disconnect you from services. Here's the huge thing that parents of young people are very pleased about. Previously, health insurance plans said that you could only keep a young person on your health insurance if you were a parent, usually if it was after the age of 18, only while they were enrolled in school or an education institution. Under the Affordable Care Act or health care reform, parents, if you have health insurance, can keep your children on your plan regardless of access until age 26. So we think that that clearly gives parents a great benefit here. Another thing that will absolutely help with health care coverage is that all health plans, which are new, and so I'm going to categorize this by saying again that there are different times when plans are required to provide this, but there is now a mandatory health care coverage map of services that plans must provide once they're required to do so, and the time that they're required depends on the type of plan. I'll explain that in a minute. But here's the services that are required once plans are in the new plan system. Ambulatory services are services that you can go to of your physician or walk into. Emergency services, hospitalization. Maternity and newborn care, irregardless of whether you had planned for it in advance. Mental health and substance use disorders. This actually implements things that we have in New York State, like Timothy's Law, on a broad scale. Prescription drugs, rehab and habilitative services, including devices to help individuals with those, lab tests. Again, we come back to this preventive and wellness services, including chronic disease management. And that's an area of opportunity for those of you that are providers or peer providers to begin thinking about a whole array of preventive and wellness services that you might offer to insurance companies to provide that service. We've previously talked about healthy eating, smoking reduction, peer support services conceptually could even be included in this. And last but not least on this list is pediatric services, including oral and vision care for pediatrics. Now, these coverage come online at different times. Individual and small group plans are covered pretty immediately. Health insurance exchanges, and I'll talk a little bit more about what those are and hopefully begin to demystify that some in a minute, but they're required to provide these. Plans that have previously existed, whether they're individual plans or employer-sponsored plans, meaning that the plans existed before September 2010, are not required to implement the mandatory coverage until those plans begin a fresh cycle or start over again. So a plan that's been in place that doesn't have a renewal and isn't finishing one and starting a fresh batch are not immediately covered, and so you should just be aware that not all plans are required to provide all of these services immediately. A limit on cost sharing. This is something that Congress and the President heard a lot about, and that is that plans are prohibited from creating deductibles that are larger than $2,000 for individuals or $4,000 for families. And what Congress said is that requiring people to spend their life savings on health insurance as part of the co-insurance cost was just unacceptable in this society. And so we've limited what are called the out-of-pocket costs that any individual can have in any one year. Now, if you were paying attention earlier in the discussion, you heard a different out-of-pocket cost limit. Remember that different parts of the plans have different limits, and so this is the mandatory coverage for all plans. This is not the pre-existing condition plan, which has a higher out-of-pocket cost between now and 2014, when all plans will come under this new limit sharing. Home and community-based services is something that has been greatly enhanced in the Affordable Care Act, and it provides a number of incentives which make it easier for people, particularly with disabilities, to live at home in their own communities rather than living in nursing homes or other institutions as a necessity in order to be able to receive services. Now, what does this mean for individuals? Well, it means that as a result of health care insurance reform, we'll actually be able to begin thinking about truly implementing the Supreme Court Olmstead decision and helping people live in the most integrated settings as opposed to living in institutions. So how does this play out for real as a result of the services? Well, one of the things that the Affordable Care Act does is it begins to create, for the first time, a voluntary insurance program which will begin in October of 2012 to help pay for services that will help keep you in your community. And so if after October 2012 you wanted to be insured to cover the cost so that no matter what happens to you, you could be able to purchase services, whether it's a home attendant, a personal assistant, home health care, ramps to get into your house, lowering counters so that they're wheelchair accessible, or other types of assistive technologies or modifications, this new voluntary health insurance plan provides coverage that will help pay for those benefits. Now, the details of this, as much of the Affordable Care Act, have not been finalized yet, but the basic concept, as it's in the statute, says that this coverage is available to working individuals who are over the age of 18 who have paid for the insurance for at least 5 years. So you can't just buy this insurance and say, oh, I'm disabled, I need the funds now. You have to have invested money, and like most insurance, you get what you pay for. And in this case, we have to pay in long enough to be eligible for the benefit. Now, the benefit the way Congress has said is after 5 years, if you become disabled or expect to be disabled for 90 plus days, then you're eligible for this insurance to pay for modifications to your home. Assistive technologies could be computers, could be readers or other devices, home health care aids, personal assistants, and other things that will enable you to continue to live in your home. The minimum average daily benefit that they expect would be $50 a day. And so that out of that you would be able to purchase other things. Now, $50 a day doesn't sound like much, but if that's the minimum, then you're virtually guaranteed of having some money come in every day in addition to other supports to help you pay for at-home modifications to assist you to be able to live there. And this program, the Community Living Assistance Services, the abbreviation for it is called the CLASS program. And so over the next year, undoubtedly you'll hear more about the CLASS program. It is a voluntary insurance program. The Community First Choice option is an option that the federal government has created to help states incentivize what are called home and community-based supports over institutional care. Now, the way that this works, and unless you're a finance or a Medicaid kind of junkie who looks at these things, Medicaid services are developed and presented to the federal government by what are called state plans. And New York State, like every other state, has a variety of plans to cover various Medicaid services that we, in fact, along with the federal government, pay for. What this Community First Choice option does is it permits states to incentivize, instead of providing services in an institutional setting, to actually pay for services up to, for individuals who earn up to what's called 150% of poverty. And so the 150 FPL is the federal poverty level. So individuals who are eligible for Medicaid, which is the MA, often abbreviated MA, are able to get home and community-based services and supports in lieu of being hospitalized or institutionalized in nursing homes if a state implements this waiver. Now, the second bullet here is one that really affects state finances. It says that the federal government is going to give states a financial incentive for them to actually implement this waiver of paying them an additional 6%. The FMAP is federal matching funds for 5 years, beginning October of this year. And so New York State, like many states, will be looking at, do we want to implement this option? Because to implement this option means that we will get more federal dollars to help support individuals with Medicaid live and receive services and supports in community and home settings. Now, a very popular program with people with disabilities is called Money Follows the Person. And Money Follows the Person was a federal demonstration grant which let states take the amount of money that they would historically have spent for someone who was in a hospital and take that same amount of money and help that person move to the community and not reduce any of the services, but use those funds to pay for that person to successfully live in the community. And so it's called the Money Follows the Person, because the money follows the person out of a hospital or a nursing home to be able to help them live successfully in the community. The federal government, this program was planned to no longer be available. The federal government has extended the demonstration grants until September of 2016. Part of the rationale for extending them to that point in time is many of the other provisions of the Affordable Care Act will provide like services and hopefully be able to help continue this movement beyond that. This really helps states help move people that have been stuck in hospitals and nursing homes long term. from being stuck in hospitals and nursing homes to living successfully in the community. And so for people with disabilities, this is a good thing. Home and community-based services. Well, there are a lot of Medicaid services that are paid for under what's called a home and community-based service waiver. The federal government, anything that New York State pays for, the federal government requires New York State to file what is called a state Medicaid plan. And so here the State.MA plan refers to one of a variety of state Medicaid plans. Under the Affordable Care Act, the statute actually makes it easier for the state, instead of having to file a new plan to implement more or different home and community-based waiver services, it allows the state to simply amend or change its plan rather than starting a whole new process and going through the mountains of red tape that it takes to get state plan amendments approved. Again, it's a huge benefit that recipients won't necessarily see immediately, but it does affect the ability for the state to offer services that are more conducive to helping people live successfully in their community. The big thing in the Affordable Care Act is the expansion of people who will be covered by health insurance. Now, for New York State, this is not as big as it is for some other states in the country because we actually had a very robust Medicaid coverage for individuals across the state. But for the first time beginning in 2014, non-elderly childless adults with services up to 133% of the federal poverty level, which is currently $14,484, will be eligible to purchase or be part of Medicaid. Now, this is a huge thing. If you're a single individual and you don't have a disability, your ability to get health insurance coverage has been very limited, and you may not have been able to afford the coverage, assuming that you could get it. By making Medicaid available to more individuals, this will dramatically increase the number of individuals who have health care coverage. Now, here's the really cool thing for people with disabilities, is that the only test for eligibility is income. Assets are no longer counted. And so if you're an individual who's on SSI, who gets Medicaid as a result of being on SSI, you know that you get SSI, Supplemental Security Income, from the Social Security Administration. It has a $2,000 asset cap on it, unless you're married, and then it's $3,000. So you can't have money in a bank, you can't own investments, you can't own other things and have any assets available to you and be eligible for Medicaid. Beginning in 2014, that asset test is removed. So the only eligibility question for Medicaid is income. This actually will make Medicaid more available to more people pretty quickly. And for people who are on other types of benefits, eliminating this asset test should help individuals qualify for Medicare. Now, part of this expansion also means that we will extend, under the Affordable Care Act, what are called early periodic screening and diagnosis and treatment for children. What this EPSDT is, it is screening that looks for disabilities in children to ensure that they're able to get appropriate care and services. And so this mandate gets extended to all children on Medicaid, including those who are in Medicaid managed care. And the managed care part was not an inclusion before. So in New York State, we have a lot of individuals on managed care. This now will extend EPSDT services to those individuals who are covered under managed care. Now, one of the most probably misunderstood things in the Affordable Care Act is something called health insurance exchanges. And so these health insurance exchanges are really quite simple if folks explain it this way, I think, or at least I hope, to understand. They are nothing more than pools of people, groups of people that get together to buy health insurance together instead of as individuals. And so a health exchange, in essence, brings every individual who is not working for an employer who offers health insurance together in a state, and it doesn't bring you physically together. This is a virtual togetherness, to allow you to purchase as a group health insurance from a large health insurance company and to pay the premium as if you're part of a large group of people. The group could be as large as 1 million or 2 million or even more in a state the size of New York. Now, this actually makes it easier to shop for health insurance because you'll have one place that you can go if you're uninsured and not part of a group to look at health insurance plans. And so here's how these plans play themselves out. There are, in essence, 4 tiers of health insurance coverage under these plans. And all the plans will have the same mandated benefits. Remember earlier in the discussion that list of mandated benefits and service? All of the plans will have that same list of mandated benefits. So the difference in the plans is how much the plan pays and how much you pay out of your own pocket. So here's how the plans work out. And so as just a point of interest, one could assume someone was watching the Olympics when they thought this out, because the plans are labeled much like the Olympic medals. The most fundamental plan is called the Bronze Plan, and it covers all the mandated services that are offered, and it pays 60% of the cost of the health care services with an out-of-pocket limit or a yearly limit of $5,950 for an individual or $11,900 for a family of how much you would have to pay as a part of your 40% of the cost. So if you want a low-cost insurance plan, these will probably be the lowest cost plans available because they have the highest deductible available. So if you want a low-cost plan, the Bronze Plan will probably be the cheapest. But if you're healthy, that works out well. But if you get sick, your risk of how much you'll have to pay if you're an individual is limited to $5,950. And those limits are true of all of the plans.
Excuse me, John, could you just let us know, what does the HAS stand for?
The HAS is the health account savings plans.
Okay.
And so there is a limit that all of these plans have to comply with the health account savings, which is another section of federal law. And so I'm sorry, I should have explained the HAS, which the $5,900 and $11,900 apply to the limits that apply to the health savings plans.
Thanks.
The silver plan will be a little more expensive than the bronze, but it's going to pay 70% of the cost. So again, you would pay 30% of the cost up to that $5,900. The gold plan, again, will be a little more expensive. It'll pay 80%, so you'll pay 20% up to the $5,900. And the platinum plan will probably be the most expensive because it will pay for the most. It pays 90% of all the cost, again, up to the $5,900. So if you're someone who's not eligible for Medicaid and you're not eligible for other insurance, and so you want to get private insurance through the Health Exchange Network, these 4 plan options will be available to you at a varying different cost by various companies. So it won't be 1 or 2 companies. Various companies will offer these depending on where you are in the state, and you'll be able to purchase them, being able to compare each of the plans to each of the providers and see how that goes. Now there's a 5th option on here, which is called catastrophic insurance, and that's available for people who are up to age 30 or exempt from having to purchase health insurance. And so given that the number is relatively small, I'm not going to talk about that at this point in time, but understand that if for some reason you were exempt from health insurance coverage, from the mandated requirement to purchase it, you would in fact be able to get the catastrophic care if you were a young person. Catastrophic means that if you had a major illness like cancer, where there were hundreds of thousands of dollars in expenses considerably for 1 year, that the plan would step in as a result of that catastrophe from the major health incident and the cost.
John, can you just clarify where it says provides essential health benefits? The essential health benefits, is that the same as what you were talking about earlier with the mandated standard?
That's correct. And so the essential health benefits are the mandated benefits that all plans, including the health exchanges, must provide.
Okay. Thank you.
So one other benefit of the health exchanges, if you are poor and you cannot afford to purchase a plan in an exchange, you may be eligible for a subsidy based on your income and family size. And so the income limit is set to 133% of the federal poverty level, or FPL, but less than 400%, which means an individual earning up to $43,000 a year could get this subsidy. Now, the way the subsidy is written, at least in the current thinking of the plans, is that individuals would get a tax credit to help them pay for not only the cost of the health insurance, but the cost of any out-of-pocket expenses. And so this would mean that you would file your tax return and you would get a credit on your tax return, much like the earned income tax credit, that would be a health exchange subsidy credit, enabling you to get money back. Even if you didn't pay in very much money, would enable you to get back potentially more than you paid in and actually help you cover the cost of purchasing health care and the cost of the out-of-pocket expenses that you might incur as a result of that. Now, the whole reason for doing health care reform was that Medicare was broke, and Medicare was going to be running out of money as early as 2017. So 6 years from now, the Medicare Trust Fund was estimated to run out of funds. By changing the law and strengthening the provisions that they've done in the Affordable Care Act, there is at least, based on the current projections, a 12-year extension for the Medicare Trust Fund. Now, how are they going to extend Medicare? Well, they're doing several things in the Affordable Care Act. First thing that they're going to look at is reducing waste, fraud, and abuse. There are actually states are receiving grants to help beef up their waste, fraud, and abuse investigations of Medicare, as well as federal waste, fraud, and abuse investigations. By focusing on coordinated care, we can actually begin to coordinate care among doctors to reduce preventable and harmful readmissions to hospitals. So all of us have heard stories of people that got discharged from a hospital and weren't able to see their doctor or didn't get follow-up in time, and their condition got worse and they had to go back in the hospital. Under the Affordable Care Act, there are actually incentives being paid to systems and providers to ensure that individuals are seen more rapidly and quickly. Now, here's one of my personal favorites, which is a limit to how much insurance companies can make in profit and administrative overhead. And so for the first time, to strengthen Medicare, the federal government has put a limit for the Medicare Advantage plan spending on administrative cost, including insurance company cost, of 80% of the benefits. And so whatever your premium is and whatever they've earned in income from payments, whether it's from premiums that individuals pay to buy insurance, or whether it's payments from government or employers as part of the copay insurance, carriers can no longer exceed 80% administrative costs, and in some instances it's as high as 85%. which I think, is a huge benefit here, which means that 80% of all of their funds has to be spent on direct benefits or quality improvement activities. Now, if you're an individual who's on SSDI, Social Security Disability Insurance, and Tony's just reminding me I should let folks know we'll take a break in about 15 minutes. We'll finish the presentation and take question and answers. But let me explain this benefit about Medicare Part D. If you're on Medicare or you're an individual who's on SSDI, Social Security Disability Insurance, and have been on it for 2 years and therefore you've gotten Medicare coverage, you know that Medicare Part D pays for your prescription drugs. Now, if you're a poor person on Medicare Part D, there is a thing called the donut hole. And the donut hole is what happens when you and your insurance company have paid for $2,840 this year in total drug cost. Once you've reached that donut hole, you as an individual are responsible for 100% of the cost of your drugs until you get to $4,500 in drug cost, and then Medicare Part D kicks back in again. What this new plan does is it closes the gap on the donut hole so that no longer, if you have the hole that affects you, will you have to pay so much. Now, I need to be clear that individuals who have both Medicare and Medicaid do not have the donut hole because Medicaid closes that 100% for you. So this is individuals who only have Medicare, who are not getting the extra help, which is a technical term that helps pay for the cost of the care. Individuals that don't get extra help or have Medicaid in addition to Medicare are affected by the donut hole. What happens beginning in this year is if you hit that donut hole, half of all brand name drugs will be discounted to you. So all the brand name drugs that you use, you'll get a 50% discount on the cost of purchasing them while you're in the donut hole, which is a huge increase for individuals so that you don't have to pay the full cost. And for generic drugs, which are cheaper by standard anyway, you'll get a 7% discount on generic drugs while you're in the donut hole. Now, something that happened only in 2010 was if you had been in the donut hole, so if you were a person who had Medicare and had exceeded that $2,800 and were paying in the donut hole, you should have received a check for $250 last year, which was part of the federal rebate to help pay for the donut hole coverage. And in New York State, 153,003 people actually got those $250 rebate checks. Between now and 2014, the donut hole and the size of it will shrink, and the amount of your copay will also shrink, so that in 2014, it will simply be a co-insurance function. It doesn't totally go away. There is still a co-insurance function, but the cost for an individual will not be in the thousands of dollars. It will simply be a percentage of the cost. Now, starting this year, if you're on Medicare, there's actually a wonderful new benefit that I want to make sure that everyone that's listening takes advantage of, which are these annual wellness visits, which allow you to go in and see your primary care physician for the development of what is called a personalized prevention plan. Now, you're entitled to do this. It's a free of charge service that Medicare will pay for, which includes an assessment of any health risks that you have. We'll give you an update on your history, actually a printout for you, a printout of your current providers, a printout of your current medications. We'll check your height, weight, and blood pressure. And then what really is one of the cool things of this is a schedule of all the health screens that you should take advantage of over the next 5 to 10 years. The whole reason for this is to help each of us take more control of our health care, and be more responsible in managing our care and preventing disease. So this concept of a wellness prevention plan, for many of us in the mental health community, we talk about WRAP, the Wellness Recovery Action Plans. This wellness visit and prevention plan could become part of your WRAP plan to actually have you take advantage and be proactive in managing your care. Now, the last part of this wellness visit includes a list of any health risk factors that you have, along with various treatment options that you have. So if you're a smoker, the preventive plan and the wellness visit will include options to help you reduce smoking. If you use alcohol, will include options that you might explore to help you reduce the amount of alcohol that you might use. Globally, the Affordable Care Act was set up to do these things, to reduce the disparities of health coverage, to include preventive care services, checkups, screenings, to coordinate care, and that coordinated care includes over $1 billion of new investments to ensure that community care can manage chronic diseases. If you're a person who has never been served by a provider who speaks your language or looks like you, the Affordable Care Act includes a huge investment in diversity and cultural competence by helping to increase the ethnic and racial diversity within all of our healthcare professions. There's a huge expansion in services for underserved communities. And in New York State, we have many rural and frontier communities where health care is difficult to access. The Affordable Care Act includes targeted funding to help expand services in those areas. It's set to end insurance discrimination and provide affordable insurance coverage access. Now, here's some stats in New York State before we close and go to questions. This past year in New York State received $1.7 million to support consumer assistance programs. That includes the ability to expand health department operations to assist people to walk up and receive information, or other kinds of services to help people be able to understand their coverage and access appropriate health services. New York State got $1 million to crack down on unreasonable insurance premiums. This is where an insurance company raised the rate just all of a sudden out of the blue without any rhyme or reason to it, and so $1 million to crack down on that. We got $1 million in New York State to begin planning for the health insurance exchange networks that I talked about, the bronze, silver, gold, and platinum plans. Huge investment, $48 million in biomedical research to begin looking at how do we help ensure that people's illnesses don't develop into more serious things resulting in disability. And we got $6.1 million in demonstration projects to begin improving the diversity of our health workforce. This is that cultural competence issue of ensuring that New Yorkers who look like me, who are from my community, who speak my language, are the individuals that I can get health insurance services from. Now, I want to point out that the official source for information about the Affordable Care Act is on a website on the internet at www.healthcare.gov. You can actually use that website to look at various insurance options and understand more detail about the changes. I also want to highlight the AARP, the American Association for Retired Persons webpage. It has a number of excellent links as well as video and trainings to help you better understand the components that I've quickly talked about today, and may or may not have more information on, because as I said, some of these things are still in a state of change. Between now and 2014, many of the implementation strategies for the Affordable Care Act will affect New Yorkers will be finally decided upon and implemented. As part of the governor's Medicaid reform initiative, that initiative is beginning to look at cost for this year, but undoubtedly the governor will use a variety of mechanisms to begin looking at how the Affordable Care Act will be rolled out, more specifically in New York, over the next 3 years as we move towards 2014. For provider and peer organizations, this concept of preventive and wellness care is a huge opportunity for each of you. Begin thinking about those services that you might offer to help address preventive or wellness care, and be in contact with a variety of managed care and other providers to think about how you might become part of those insurance panels or list of providers to be able to deliver those services effectively for New Yorkers. And so with that, I think, Tony, we have some time for questions. So Tony's been keeping track of the questions, and he'll read them to me, and hopefully if I know the answer or can direct you to it, we'll try and address them.
Just pull the microphone over. Okay. Can you explain how this would affect me with my SSI?
Well, how it's going to affect you with SSI, the Affordable Care Act should not affect your SSI at all. What it may affect is your Medicaid as a result of having SSI. Now, the rules aren't totally written around this yet, but a number of us that have received federal and other briefings on this matter believe that what's going to happen is the current services that Medicaid pays for are likely to begin morphing to more closely match the mandated services that we talked about in the mandated health plans. And I'm going to flip back up to those mandated services so that people can see them. Because Medicaid currently pays for a whole host of things that are way outside of this list in ways that are very broad beyond this list. The federal government has said that it is very concerned about what they call churning. And churning means people that are on a health insurance exchange, but then they become eligible for Medicaid, and then they lose Medicaid and go back to the exchange, and then they lose the exchange and go back to Medicaid, and they go back and forth, i.e. churn in the water, if you will. What the federal government has said is that they're concerned about is if the benefits are not the same, there will be a disincentive for people to move off of Medicaid into the health exchange networks as they improve or conditions change. And so what I suspect, based on what I know today and what I've heard from various federal partners, is that nothing is going to change in regards to your SSI or supplemental security income. But in fact, Medicaid will change to more closely match the services that are provided by the health exchange networks. And that's a set of things that has not been fully decided yet and will play out between now and 2014. So next question, Tony.
Hang on, I lost it here. Okay, are there any concerns about the elimination of Medicare Advantage in rural counties where replacement insurance would be 5 times the current Medicaid costs?
Well, at present, there is nothing in the immediate plan that would eliminate the Advantage plans in rural or in other counties. And in fact, what the Affordable Care Act does is simply limit the amount of administrative overhead that those plans can operate under. It doesn't eliminate them. It simply limits the amount of overhead that they can charge either the state or others. And so as part of the movement of everyone towards health insurance, whether it's Medicaid or a health exchange network or an employer-based plan, and we didn't talk about those today, nor did we talk about the benefits for retirees. There's a number of other provisions in the Affordable Care Act that we didn't talk about today. But the global concept is to ensure that we don't lose health insurance, so we're not going to be getting rid of things, but we're going to be actually morphing them to change so that more of the things look similar to each other so that people can access consistent services regardless of whose plan or system that you're in.
So is it possible for providers, I mean, are providers able to refuse to see certain patients who receive certain kinds of insurance, like Medicaid? I mean, I'm paraphrasing a few of the different questions here around, refusing to serve people, and that, having insurance would be irrelevant if you can't find a provider to provide the services.
That's actually an excellent question, and I'm going to just digress for a minute. Many of you that have either seen me present or been part of our provider networks have heard me talk about Dr. Joe Parks from Missouri, who's the president of the NASHBID Medical Directors Council. Joe and I were together at a meeting with the federal government being briefed on this, and he actually asked that question directly, and then I asked the follow-up, which is, could a provider, based on their belief or capacity, simply refuse you services? And what we've been told is there are two mechanisms by which a provider can refuse services. One is if they believe that they cannot effectively treat you or that your treatment is beyond their expertise. Now, that's a pretty big catch-all and enables providers to simply say, well, you're beyond my level of experience, so I'm not going to serve you. The other catch-all that the feds seem very clear on is based on medical necessity. And what the federal government told us, at least in the briefing that we had around December, was that they were not going to set a standard for the medical necessity rules across all the insurance plans, which means each plan will have its own medical necessity criteria. So although all the plans will have the same benefits, your ability to access the benefits will vary under each plan by its medical necessity criteria. And so as we learn more about this and as the plans are developed, we'll try to educate people more about that process. But the simple answer to the question is providers under the new system, just as they can today, can refuse anyone that they believe that they cannot effectively help, which gives a pretty broad latitude to providers to make treatment decision choices.
Thanks. Next question. Is there any paperwork that helps me educate the people who feel that they're being forced to buy health insurance? Are there any brochures or any easy access forms out there?
Well, that's a little more complicated because many people under the Affordable Care Act will be encouraged, if not forced by their employers and others, to actually purchase health care coverage in the same way that every individual who works is required to purchase Medicare. You don't have an option to opt out of it. There are a number of websites online that have accurate information. I would actually begin by using the web page that I put up here at the end, and I'll put it back up here again for people to look at, the healthcare.gov, which has a bunch of very specific information pamphlets on if you're an individual, if you're a parent with a child, if you're a person with a disability, if you're a senior, that can help educate you about how the Affordable Care Act will directly affect you and about what your requirements and responsibilities under the Act will be. Also, if you wanted an interactive training, some of the best videos that I've seen on this are available from the American Association of Retired Individuals, the AARP, and their webpage has a whole healthcare section as well with more than a dozen, I think, video presentations on various parts of the Affordable Care Act.
You mentioned AARP, and we do have a concern in our question log here about AARP and that there may be bias in the information that they present.
Well, any information that anyone presents is obviously biased, including me. So you've gotten my biased views on the Affordable Care Act, and I will admit that it's my particular view. Anyone that is presenting, you're going to get their particular view, and healthcare.gov, you'll get the government's particular view. There are lots of web pages online where you can counter a particular point of view with another and try to look at what the difference is. What I hope I've done today is try to present as accurate a view as we understand today of what the intent of the statute is and what its effect for people with diagnoses are. AARP is a provider of Medicare Advantage plans and services. They do endorse a lot of services, but they're also one of the largest advocacy organizations in the United States. And so whether or not you agree with that, they're beholden to their members, and so they're going to present the view, I think, that is most supportive of their membership, irrespective of how you believe that. So, but clearly everyone presents a biased view from their perspective, and so there are lots of web pages where you can go to try to look at the balance on the other side.
Where does mental health fit into this plan? I.e., will it be carved into the rest of health as a result?
Well, clearly, healthcare homes are something that are part of the Affordable Care Act, and I didn't talk extensively about that, but there's a huge incentive for states to implement health homes. And in fact, as part of the Medicaid restructuring commission that the governor has announced, they'll be making a decision about healthcare homes, whether they are, in quote, to use this person's question, carved in or carved out. What that means is simply that managed care, a carve-in is managed care would pay for all services, including mental health, and a carve-out means that either individuals or services would be paid for by a separate managed care system that would cover either mental health care or mental health and all care under a specialty system. That's a decision that has not been decided, but the concept of health homes actually has been decided. And so the federal government believes that there are huge cost savings if, in fact, everyone has a place where individually they will get coordinated care from. And that place is called a health home. It's not a physical home, but it is a doctor, a clinic, a service that I go to that is responsible for managing and understanding all the healthcare services that I receive. And in fact, the federal government has incentivized states to implement health homes by providing what's called a 90% federal Medicaid match for a period of 2 years. So New York State is in the process of looking to implement health homes today. I can't answer because it's not been decided yet whether it will be a carve in or carve out as the question was asked. There's a lot of advocacy and activity around that issue. And so if you have concerns about you favor either a carve in or you favor a carve out, you should certainly seek out one of the advocacy organizations, make your voice heard, but that's a decision that has not yet been decided.
Thanks. Is it mandatory for parents to keep children on their plans until they are 26?
Excellent question. It's not mandatory, and in fact, not all parents have health insurance, nor are all parents able to access health insurance. So if you don't have health insurance, you can't be mandated to keep your child on. It is simply an option to let you, if you're able to afford it, you have the health insurance coverage, you can in fact keep your child on, but it's not a mandate.
Thank you. Will there be any administrative cost parameters or profit ratios imposed on providers, especially hospitals and specialty care?
Well, that's an excellent question. Given that plans, both the health exchanges, the Medicare Advantage plans, and ultimately health insurance companies are going to be required to spend 80% or up to 85% of all of their resources on direct care or quality improvement. And I'm using that "or" intentionally because some administrative costs could be argued are quality improvement. I suspect that in order to do that, the organizations that provide care at some point are going to be required to have similar kinds of ratios, because if I'm paying for administrative overhead, then how is that being calculated across multiple systems? Now, there are no direct discussions on that issue today, but I suspect that managed care, which is good at keeping costs down by directly managing its requirements to its provider network, will take that 80 to 85% requirement that managed care has and translate that to the provider network. That's simply my assumption based on what I know historically. It's not mandated in the statute.
Okay, thank you. So will insurance companies pay for outpatient chemical dependent services based on the clinic license, the facility license, or will the insurance reimbursement be based on the rendering practitioner's professional license? Can outpatient chemical dependent clinics become health homes?
Well, that's a huge loaded question, and I'm not sure that I can give you a definitive answer today, and so let me start with the last question first. So can chemical dependency clinics become health homes? The concept of a health home is a fully integrated place where an individual can get all of their health care. So if the only service that I have people licensed to deliver is chemical dependency services, then it does not meet the concept of a health home, which would include somatic health care services as well. The Office of Mental Health with the Department of Health in the last year as part of clinic restructuring has implemented that mental health clinics can in fact provide somatic health services under a single license, up to 5% of the visits for the mental health side, without being required to get a Department of Health Article 28 license. Those clinics, if they had the appropriate clinicians able to deliver somatic services, could conceivably become a health home for certain individuals. Now, this kind of goes to the carve-in, carve-out question, because some of it remains to be seen on whose sets of rules are going to apply and which agency or managed care provider is the ultimate keeper of the rules. So I can't answer the definitive. As to whose license and how will it be paid, that's a question that each managed care or each insurance carrier will make those decisions about how it will reimburse its network of providers and how it will make payments. Now, the one caveat is that the Affordable Care Act suggests that all providers should be paid at a minimum the Medicare rates. Now, for many providers, the Medicare rates are much lower than your current rates, but the Affordable Care Act does set a minimal standard, which are the Medicare rates, not Medicaid, the Medicare rates. And so as a basic threshold, that is one of the provisions. In New York State, we have had discussions with the health department about requiring insurance and managed care providers to pay the state Medicaid rates specifically for mental health care. And as part of both clinic restructuring and Medicaid restructuring, those are still ongoing discussions.
What info do you have about demonstration projects to improve diversity and developing cultural competence?
Well, as I said, and I'm going to flip back up to that slide, New York State got $6.1 million in demonstration projects. I would refer you to the healthcare.gov webpage where you can get more specifics on each of these, as well as a whole host of other funding that's available. You can actually look at any state, what it got, and to the extent that the page has information on actually how they're using it. And it'll give you a much broader description than I was able to give you today.
Okay, one more question. Can you describe the difference in health home and patient-centered medical homes in terms of actual implementation?
Well, given that the implementation rules have not fully been written or finalized, the big difference is that a health home would be responsible for coordinating and exchanging information across multiple providers. And so the concept would be that your provider, which is your health or medical home, would be able to have access to all of your tests, treatment, and other information and help coordinate across all of your providers' care and treatment. Now, this is really simple, but yet really complicated. The simplicity, and I'm going to use a mental health example that will hopefully illustrate how simple and complicated it is that we know with mental health care, many psychotropic drugs actually increase the risk of diabetes or hypertension as a result of weight gain and other factors. It's described in the NASH-BID morbidity and mortality report, as well as other reports and research that have been done nationally. If I'm getting psychotropic drugs and I'm not getting appropriately screened for diabetes care, then my risk of diabetes runs up as a result of getting psychotropic medications, which may increase my blood glucose and insulin levels, or may increase my weight to such a point that I am now further at risk of diabetes. And so the concept of integrated care means that my doctor that's prescribing my psychotropic drugs needs to be in touch with my doctor who's prescribing other care and treatment for me, so that we coordinate this risk with real assessment at the same time and provide integrated treatment, as if we're not speaking about two different parts of the body, but we're speaking about a person's body singularly. Now, the complicated factor is very few clinics are located with mental health providers, and very few mental health providers are located in somatic clinics. On the mental health side, we're doing a little bit better. On the somatic side, actually, lots of people are seen in private clinic settings for things like depression and other diseases, but not so much when we start talking about what are considered the serious and persistent mental illnesses. It gets very complicated because our systems were not originally designed to talk to each other, nor do we have offices in the same buildings, let alone share the same services so that we can more effectively communicate. There are a number of projects underway, including electronic medical records, which will help speed up this process, but the implementation of those is also spread out over a multiple year period of time, will undoubtedly help with the process. The whole concept of a health home, in the broadest or most ideal sense, is a single place that I can go to get mental health care, addiction care, or care for any somatic condition that I have, and the doctors and clinicians can all easily talk to each other because they sit within the same practice or within the same organizational structure, or they have mechanisms to share information more freely. That does not exist in the ideal today in very many places. We do have a couple places in New York State, and the one that immediately comes to my mind and I want to highlight is Maimonides in New York City, which has a fully integrated clinic that includes clinic services and specialty mental health and other services. And so there are a few examples. They're clearly not the only one in New York State. There are many others. But it is still the exception today. If I go to my private general practitioner, they see me for one set of things and then refer me to other people who independently see me and run their own test as if they're the only one running tests. So I hope that explains it.
John, thank you very much. I really appreciate you taking the time to do this webinar, and I think people got a lot out of it. I'm going to highlight our next month's webinar. Next month we will be doing an introduction into the 507 planning process, including having dates available for people in April to join us. We will be soliciting input from families and recipients in April, and this is just an introduction to what the 507 plan is and how you can be helpful in getting your voice heard in it. So again, thank you all for coming. There will be a window that pops up for you on your computer screen. It will have about 4 or 5 questions on there. If you could please just take the time to answer those, that would be great. And we look forward to seeing you next month, hopefully. Take care, everybody. Bye-bye.